Now and have been on the line. We appreciate you spending your Friday morning with us. Please enter your name and your organization in the chat. We'll keep track of attendance through that mechanism. Again, welcome and happy Friday morning. Do we have Commissioner Brooks on the call? Commissioner Brooks? All right, so I believe we will not be having Commissioner Brooks join us today. She's usually our chair, as she is the chair of the board and leads the SCRILS meeting. But in her absence, I will be filling in. So I appreciate everyone's recognition that Commissioner Brooks will not be chairing the meeting today due to a separate scheduled event that she had to be at. All right. Before we get started, we'd like to open this up if there's any immediate questions, concerns, or input. Anything in the chat? Hearing and seeing none. We'll get started right away with our agenda. Do we have the Healthcare Authority on the line?
Good morning, Justin. I think there's a group of us a few of us on, and so good morning. We're ready to provide updates.
Excellent. Well, then I'll turn it over to Teresa and the team. We'll go right into general updates for the Healthcare Authority.
Thanks so much. Teresa Claycamp, I'm one of the deputy directors within DBHR. I'm also joined by my colleague, Scott Tankersley. We are prepared to just do some updates on the budget as well as some updates on the bills that were passed. We do have a short slide deck we'd like to present. Is it okay if we do that, or?
Absolutely.
Yay. And it's not me that's presenting, thankfully, because I'll mess it up. Okay, so we just have a few slides. So I'll kind of review the first couple slides on the budget overview, and then I'll pass it to my colleague Scott, who will talk about the bills that were passed. So you can go ahead and move it to first slide, Scott. Thank you. So folks know that sine die, or the end of the legislation session, was the end of Thursday, March 12th. So we've just passed that benchmark, if you will. DBHR, we followed numerous bills throughout the session, and there were a lot of bills, actually, but not very many passed, honestly. So a lot of action, but not a lot passed, and Scott will go over what did pass. Before talking about those bills, we'll talk about the budget. We continue to unpack the budget when we're still analyzing it, and that's pretty common. And just overall, the legislator did make some challenging decisions due to the current budget climate. So we'll talk about some of the cuts. There's also a 1% administrative reduction to the agency. So that's going to impact either goods and services, travel, et cetera. So we're still looking at that 1% reduction and analyzing how we're going to implement that. It could have been worse, honestly. And so we're relieved, although reductions are never what we want to see, right? So as far as some of the reductions go, we did have some reductions specifically to programs that do diversion services. So we had reductions to the law enforcement assisted diversion, or LEAD grants. And I don't have the specific numbers in front of me, so my apologies, but these are kind of general areas where the reductions are seen. Some varied from 10% to 30%, somewhere in that range. So the LEAD grants had some reductions. The arrest and jail alternatives had some reduction. Health engagement hubs reduced. Recovery navigator programs reduced. Alternative response team grants also reduced. We also had some reductions in recovery support, so clubhouse services and Oxford House expansion. So those are some of the areas that we'll see some reductions. There were also some eliminations, mainly in the technical support arena. So not necessarily direct services, but more technical support. So we did see elimination of the Bridge Coalition, technical assistance or support, recovery residences, the UW's Evidence-Based Practice Institute, MOUD in jails, prescription opioid education, peer emotional support network, and contracts with statewide recovery organizations and mental health education and support. And then there was a transfer. This is where they're transferring essentially our DBHR suicide prevention and mental health promotion funding and transferring it over to DOH to consolidate under DOH. So that is one of the transfers that is occurring within the budget. Next slide. And then you're going to see some funding swaps. So, this is where we're kind of swapping some different funding sources. There's a lot of strategy, I'm sure, in this. So, one of the swaps is Behavioral Health Housing Fund, switch from general fund state to the criminal justice treatment account. So that was a switch or a swap. And then the street medicine pilot funding switched from GFS to federal Medicaid appropriation equivalent to the match amount. So those are a couple swaps, both of which are about 1 million, 1.5 million. And then there were some investments. There was some good news. So there was funding to expand enrollment for the Parent-Child Assistance Program, PCAP, by 32 slots. There was also funding for 2 certified community behavioral health clinics as part of the Washington's participation in the federal demonstration project that that's underway. So we had hoped for more, but we got two CCBHC or funding for 2 clinics. Funding was also created to do a statewide implementation roadmap and funding plan for the Crisis Stabilization Unit and Crisis Relief Center. So that is going to be new work with a very quick turnaround, but that is in the budget, and funding for Recovery Cafe services in Kitsap County. So that's kind of an overview of the highlights for the budget. And I'll go ahead, and again, we're still having to analyze and figure out how to implement on all of that. So we're still digesting the information. The governor will sign the budget within 20 days of signing die. And then, the reminder that the governor can sign bills into law or veto all or part of a bill. So that is something that could still be in play. And we'll see what happens there. So I'll pass it over to Scott to provide an overview of the legislation that was passed. Thank you.
Thank you, Teresa. Hi, everyone. Scott Tankersley here with the Healthcare Authority's Division of Behavioral Health and Recovery. Like Teresa said, just going to chat through some of the bills that passed in this recent session. So going to kick us off with Second Substitute House Bill 2429, Supporting Children and Youth Behavioral Health. This is a bill really carrying the Washington Thriving Strategic Plan forward, an aim of establishing a statewide system of care model for children and youth behavioral health services. It requires the governor to establish a leadership council to coordinate and monitor the implementation of the Washington Thriving Strategic Plan across all partnering agencies. Another bill that relates to a similar arena, engrossed third Substitute House Bill 1634, providing school districts and public schools with assistance to coordinate comprehensive behavioral health supports for students. This bill aims to strengthen the cross-agency coordination between public education entities and behavioral health partners by providing school districts and public schools with assistance to coordinate comprehensive behavioral health supports for students. It requires OSPI, or the Office of the Superintendent of Public Instruction, and the Educational Service Districts to develop a technical assistance and training framework for school districts and public schools, an aim of optimizing that delivery of and coordination of behavioral health services for students. House Bill 2254, providing flexibility in the partnership access line assessment to cover administrative costs. This was a piece of healthcare authority agency request legislation. Washington operates 4 telephone-based PAL or partnership access line programs aiming to improve behavioral healthcare access at no cost to individuals, families, and providers. And these lines provide elective consultations to community physicians who are treating children with complex behavioral health symptoms. And so House Bill 2254 really allows for those reasonable costs for a third-party administrator to calculate and administer the assessments to be included in the proportional share calculation for that PAL line, for that funding model for the PAL line. So substitute Senate Bill 6194 allows for any rural hospital located on a federally recognized Indian reservation to be paid at 150% of the fee-for-service rate for inpatient and outpatient Medicaid services starting January 1st, 2027. A bit about substitute House Bill 2405. That bill establishes a pilot program in the Department of Labor and Industries, or L&I, to allow workers' compensation coverage for post-traumatic stress disorder treatment up to a specified number of sessions. Senate Bill 5988, establishing fee authority for accreditation services provided to opioid treatment programs by the Department of Health. This one authorizes DOH, or the Department of Health, to become an accrediting body for opioid treatment programs, and it directs the Department of Health to establish accreditation fees to cover the costs associated with those activities. Just a few more here. Substitute House Bill 2152. 2152 permits the use of medical cannabis in hospitals, nursing homes, and hospice centers for qualifying patients with a defined terminal condition. It also directs the creation of policies and standards relating to the use of medical cannabis in these facility settings. And then finally, substitute House Bill 2476, modifying the Spirits, Beer, and Wine Theater license. Like it says, modifies the theater license by increasing the maximum number of seats per screen that a theater may have to hold a license by 80 seats, from 120 seats to 200 seats. And so if the theater is frequented by minors, the bill directs licensed theaters to submit an alcohol control plan to the Liquor and Cannabis Board, which must be approved by the board prior to minors being allowed into the theater. With that, happy to take any questions that folks may have, or if you have bills that you all were watching that you want to raise in this space, feel free. Otherwise, I'll step back. All right, thank you all very much.
Thanks, Justin. Yeah, if folks don't have questions, I think the other update, Becky Carroll is here to provide some updates on 1813, and then we don't have somebody specific for the rural health transformation topic, but we do have a resource that we can put in chat and maybe work towards the future, bringing somebody in the future, but we didn't have anybody available today. So I'll pass it over to my colleague Becky to talk about 1813, and I'll chime in as needed as well. Thanks so much.
Well, good morning, everyone. Thank you for having me again, Becky Carroll, and I serve here at Healthcare Authority as the Deputy Division Director for Medicaid Programs. So my team oversees, as you probably are aware, the managed care contracts as part of its book of business. So we've been working very closely with DBHR, and specifically Teresa and Cara and a couple of others on the DBHR team towards implementation for 1813. And for those of you who maybe aren't following the details of this, this is really additional sort of embedded crisis services being delegated from our managed care organizations to the BHASOs. There are several things that have to happen prior to that delegation coming into effect. I'll say we are still centered and aligned on ensuring that happens by July 1st of this year. So coming up here quickly. Part of the kind of phases to make this all happen is the pre-delegation audit work, also referred to here and in the managed care world as readiness review. And so we are in the midst of that. BHASOs have the audit tools from the 5 managed care organizations and are preparing responses. Those will go back to the MCOs for review, and where needed, we'll provide technical assistance, healthcare authority, and the MCOs to the BHASOs, and with the hope that everybody passes and we can continue this work for July 1. I'll note that concurrently, there's conversations around contracting. So this will require an amendment to the contract that currently exists between MCOs and BHASOs to expand and include these additional services. So this is sort of where we're at the moment. I don't have any slides today, but I thought a verbal update might be a good thing, and certainly happy to answer any questions that folks might have. And I'm sure if I can't answer them, maybe Teresa can. We can do this together. So, any questions?
I would just say thank you, Becky, for that update. That is on our agenda later under the BHASO section. So you kind of helped lead into that conversation. So just want to say thank you as the ASO is currently underway in that work in partnership with the HCA and the managed care organizations to get that implemented by July 1st. And for those on the call, that pertains to services that are currently provided at our Spokane Regional Crisis Stabilization Facility, specific to the mental health stabilization service, and will in the future state also cover the crisis relief services that are provided at the new PATH Center that we're moving towards, as well as the Alliance Stabilization Facility up in Stevens County.
Well, if there are no questions, like Teresa, I'm sorry, don't have more information around where we're at with our rural transformation project, but I see Teresa's already put the notice of award document into the comments. So happy to answer any other questions you may have for Healthcare Authority, Teresa and I. Otherwise, I think we've covered our topics.
Yes. Right. Thank you. I
Thank
believe
you.
you have as well. Seeing nothing in the chat. Any last questions or input while we have the Healthcare Authority here? Seeing nothing, hearing nobody. Thank you so much, Healthcare Authority, for the updates. Although this was a short, well, it feels like one of those short in-between sessions, the next one being in 2027 for the biennium, a lot of big questions and topics to cover. I do really appreciate the support Healthcare Authority provided, and very appreciative that the Ledge recognized keeping DBHR, the staffing there intact, as a benefit to providing services in our region. As we look towards 2027, a lot of different things to address, especially Crisis Relief and Sobering Center and related projects and funding. So, Teresa, thank you and the rest of the team for joining us this morning.
Thank you, Justin. Really appreciate it.
Yep. Looks like we had a hand up from Scott. None?
Hi there, that was a mistake. Sorry about that.
Okay. Wow, I was going to say, if you're really eager, go ahead, but
Sorry about it.
Excellent. All right. Thank you so much. We'll turn this over now to Katie Lindstrom with the Department of Health, who is welcomed back to share a little bit more of an update on the 988 suicide prevention line and project across the state. She joined us at our last meeting, but I thought it'd be great to have her back and just touch base on what is the current update, especially with news that was pushed out regarding the potential limited funding availability that halted some of the infrastructure investment that was planned to go forward this year. So a lot of individuals hadn't heard the background of that or what some of the impacts of that would be. So bringing Katie back, I'll turn it over to you to share a little bit about what you've been doing.
All right. Thank you so much. And thanks for having me. I do have a few slides. Is it okay if I grab the screen? All right.
Absolutely. Turn it over now.
Perfect. There we go. Let me know when you can see what I can see. Is that showing up for you guys? Awesome. Thank you so much. All right. So yeah, Katie Lindstrom. I work for Department of Health with the 988 section. And I've been helping to oversee some of the hub designation and RCL hub transition that's going to be coming forward here later this year. So just a few updates for you all. First, actually, I'm just going to start with some data just to share. I think this is just interesting as an FYI about the growth of 988 over the last year. This chart here is showing growth from 2024 in call volume compared to 2025 in call volume. And you can see the Spokane region is down here on the bottom, and actually has had the most growth of any region. There was a 66% increase in call volume from 2024 to 2025. The system as a whole is at 37%, so that growth is happening everywhere, but you guys kind of knocked it out of the park in terms of growth over the last year. And I'm just kind of showing this just to kind of set some context that even though the tech project is going to be on hold for now, um, there still is a big push or a movement, I suppose, towards people using 988 as a front door to get into the behavioral health crisis system. And so a lot of the work we're doing right now is sort of regardless. The system is growing, and we want to just make sure that all the pieces of the system are working better together. So a lot of that transition work now is really focused to that end. So just wanted to share that. Also, just to show that Frontier is overperforming in terms of their share of all statewide calls is 13% of all statewide calls, where the population is 8%. So they're overperforming there, which is fantastic. So I think I shared this slide the last time I was with you just to show the big picture of the hub designation and transition process. We've moved past the stage here. This was where we designated the hubs. There was no change for your region. It's was Frontier and will remain Frontier moving forward as your provider. We're in the January to June phase right now. So what we're really focused on is supporting our hubs towards readiness for the transition in July. The hubs have all completed a first draft of a readiness assessment tool. The readiness assessment tool has been a way to sort of inventory readiness towards some new requirements, different policies, procedures, making sure that training is all up to par, and just kind of getting some partnerships in place as we move towards that transition. So that's really where we're focused right now. We're also close to getting the contracts ready to go, budgets finalized, so that everything can kind of kick off and run in July. And I will note, Frontier did complete their first draft of the tool on time, and they are on track. So we have no concerns at all. Feel like things are moving very well in your region, and actually throughout the state. All of the hubs are doing really well right now. I will preface, this is a draft, but we've modified this a few times, and this has actually been updated a little bit, especially since the pausing of the tech. Just a visual to show the different access points and ways for people to get into the behavioral health crisis system or receive behavioral health services. The previous version of this had the hub being sort of the main front door, and then referrals to services from there. But since the tech has been paused, we've kind of updated this to reflect it's almost kind of a no wrong door approach to receiving crisis services. So a person can obviously call 988 to get help at 988, but if they need a referral to the RCL or to receive escalated services, they can certainly do that through 988. You can also call directly, and this is reflecting what's happening across the state. All the regions do handle it a little bit differently. If a person calls 988, there can be access to get a referral over to a mobile crisis team. And then really that RCL is where then the referral to the escalated service happens. Also, just this has been updated to reflect that professionals still have that direct access to the RCL. I think there was some talk over the last year of those RCL 1-800 numbers phasing out and being transferred to 988, and that is not happening at this point. So this has just been updated a little bit to kind of reflect some changes. And just thought I'd share the image. Sometimes I know that can connect the dots better than words. All right. So what we're really focusing on right now in terms of that readiness, in addition to just readiness in terms of policies and trainings and whatnot, we're also moving, we're not requiring, but we are encouraging the other hubs to move towards an integrated model. And this is what has been happening in the Frontier and Spokane region since the beginning of 988. So we're actually kind of using what you all are doing as a model and an example, and kind of encouraging other regions to adopt, either the same or something similar in terms of the integration of 988 and RCL. In other regions right now, those are mostly separate systems where it's a separate set of staff who answer each line, and there's physical transfers of calls between the two systems. In your region, that's been more integrated, and that's something that we're looking to support other regions in developing. So we see a lot of advantages to this, especially in light of the current budget picture. We do think that regions that are integrated, where the 988 and RCL staff are the same staff and there's that integration, we do think there is a potential for increased Medicaid revenues in other parts of the state, just because there's more contacts, more opportunities to encounter individuals when you do have that integrated kind of streamlined system. Also, we think there's an improved help seeker experience to not have to be bounced around in between phone systems so often. So that's obviously a big reason to move this way. And then there's the administrative overhead cost savings between the 988 and RCL systems and simplified partnerships. So just wanted to kind of share. This isn't as relevant to you all because you're already doing this, but wanted to let you know that we are kind of moving this way with the rest of the state. And also just, I guess, kind of a shout out, especially to Justin. He's been very helpful in helping us to understand this integrated model, and helping to kind of put this together and present and work with other regions to develop something similar. So I do want to say thanks for that, Justin. It's been very helpful and appreciated. All right. So kind of what is coming up next? So we've been meeting with all the ASOs. Actually, we wrapped up ASO meetings at the end of February to understand their intentions towards integration. We're going to be working with the ASOs plus the hubs to develop and solidify the integration plans between now and June. And then kind of something that's happening at maybe a little bit of a higher level upcoming is we're kind of working towards formalizing our partnerships between the ASOs, DOH, and HCA. We're each, as agencies, kind of co-funding this one crisis continuum and wanting to work towards a more integrated, collaborative funding and oversight model of the continuum across the three agencies. And I think that we work well together now, but there's room for increased collaboration. We recently, actually, Jan and Justin joined us at a policy academy in Milwaukee, a SAMHSA Policy Academy. And one of the big goals for that work is going to be to kind of create a system vision and identify, some values and just kind of memorialize and commit to how we're going to work together as co-funders and co-overseers of the different parts of the system. So I think that's going to be really exciting work. It's going to be happening over the course probably of the next year or so, but really focusing on creating that system vision, maximizing and braiding funding, identifying opportunities to create efficiencies there, seeing what we can't do about streamlining some of our data collection and data reporting, and then also system evaluation. So we're evaluating the system as one continuum rather than separate components and separate data dashboards kind of located in a whole bunch of different places. Also streamlining and developing where necessary any of those partnerships with external partners like PSAPs and tribes, and then possibly looking at streamlining some of the training and workforce development between the systems. So this is exciting work. Like I said, we spent a few days together at the Policy Academy. There was a team of 8 of us who traveled, and then there's a larger 25-person team that will kind of continue that work, probably monthly meeting kind of situation to try to achieve some of this. So I think this will be, again, this is going to be, I think, valuable work, especially given some of the funding limitations, because I do think that we can maybe mitigate some of the funding and the tightness within the budget by working together more effectively. So, and then this is my last slide. Just kind of this doesn't really go together, but I was just trying to throw together whatever else, maybe some updates that might be useful for y'all to hear. So as I had mentioned, the tech project, I think you've heard that was not included in the budget, so that is being shelved for now. And then the other is the Frontier 988 diversion project. Just as an FYI, I don't know if you've seen this data, but I talked to the diversion coordinator and he said that things seem to be going well in your region in terms of the 911 diversion project. And it looks like you had 1,800 calls last year. So those are calls that are diverted from 911 to 988, which is obviously, we're always trying to make sure people are getting the care they need, but also not escalated if it doesn't need to be escalated, and not law enforcement involved if it doesn't need to be law enforcement involved. So we really like to see that those calls are heading over to 988 when appropriate. So with that, that's all I have. I can take any questions you might have. But again, thank you for the time.
All right. Any questions for Katie? The chat or hands? Seeing none. Of course, Katie, I have to throw in my 2 cents. Really appreciate the work and the partnership that Department of Health has done over the last couple of months to understand and get and solicit feedback on what is working, really getting feedback on our region and the impacts, challenges, and working with our 988 and RCL Hub, FBH, who truly have been partners in pushing a lot of this work. So, we got started early and we began working on knowing that we were going to come to this point. And I think during that period of time, there was a lot of questions, but the intent and goal was to ensure that our region had no issues with the implementation and that individuals receiving a call had a more clear and streamlined process. And I really do appreciate how our region has quickly gone that direction, looking at 988, serving individuals across our 6 counties. And the biggest thing was, and we have heard, that there is no significant impact to how that RCL switched over to 988 as a front door, and that individuals continue to receive that service. So really thankful for the hard work of FBH to make that happen. And Katie, it's always fun to go out and tell other people how we're doing good work, but then to also recognize we still have a lot of things to work on here as we lead towards a truly integrated system. So look forward to HCA, DOH, our hubs, and the ASOs working closer to further make that process easier and better for the individuals being served.
Yes, thank you, Justin. I totally agree on all fronts, Frontier, and also just working with you guys. It's been really, like I said, it's just been really helpful, and we love that you've kind of been moving ahead and you're sort of trailblazing this because it gives us some good example and just helps us learn as we support the other regions. So really appreciate you guys.
Wait.
And Kelly, I know you're on the line. Did you want to share anything from FBH?
Yeah, Justin, I just put in the comment too. Katie, I couldn't agree more with both your and Justin's comments. It is always very exciting to be the trailblazers and the ones to inform best practice, but there's a lot of work to accomplish. And it couldn't be done without the partnership and definitely support of our ASO, but that we work very closely with them. And I think at the end of the day, one of the things that we're just really proud of is it cannot be confusing for the call seeker. We got to get this right so that individuals calling get the appropriate help they need and the immediate help they need. And just always appreciate DOH's support and guidance and encouragement to make sure we're getting it right for our community.
Thank you, Kelly. And it's definitely something we'll bring back to the SCRILS as we look towards the biennium. This topic's going to come back up about supporting and funding the 988 system. Again, just recognizing that when they started on this project, there was a projected cost. Now we're seeing the actuals come through as to what the need is. So we'll continue to bring this forward and identify areas where stakeholders, community members can definitely share support for how this representatives in our region need to hear about the benefits as well as the needs. So we'll continue to make that available, and of course, invite Katie and team to come back and share. Thank you so much.
Thank you.
All right. Moving on to our next topic, we have a guest with us from Multicare. Actually, this is really exciting. We've met with Sarah on a couple of different occasions, identifying new programs, and recently a big project finally was identified as moving forward. So I'll let her share about this, but it is truly exciting as we look towards new not new, but really innovative ways to maximizing and enhancing the outreach and engagement, especially as it addresses opiate use disorder and fentanyl use in our community, really looking at the needs and being responsive to those individuals. So without further ado, I'll turn it over to Sarah Welty over at Multicare.
Good morning, everyone. Can you hear me okay?
Yes.
Great. So thank you so much for the invitation and that introduction, Justin. My name is Sarah Welty. I am the nurse care manager for the medication for opiate use disorder team. Although I've recently added stimulant use disorder to the title, I'm not sure how to squeeze that in yet. But essentially what I do for Multicare is I see patients here in the Inland Northwest who present with complications related to substance use disorders, whether that's starting on medication, whether that's post-overdose, whether that is they've been admitted to one of our hospital systems and they're experiencing withdrawal symptoms. I'm pulled in to kind of consult and figure out how to best treat these patients so that they get the care that they need while they're with our services. And we were very fortunate. So we are funded, my position is funded through the HCA as part of a SAMHSA grant. And we are one of 2 nurse-led, hospital-based opiate use disorder teams in the state. The only one here in Eastern Washington is our team. So I think that's pretty cool. But the other really cool thing that we started was in response to the opiate crisis here in Spokane, which is very unique. The rest of the country has seen kind of a reduction in overdose deaths, anywhere from 17 to 25%. We saw a reduction of 2 people last year, which is well behind the curve. So we know that the opiate use crisis is still an epidemic here in Spokane County. So in response to that, we have started at Deaconess in the emergency department a pilot program that allows us to now treat patients with opiate use disorder with a long-acting injectable buprenorphine. We use Brixadi. There are 2 on the market, Brixadi and Sublocade. They're essentially the same thing. But it allows patients to receive an injectable in the emergency department that covers them for 5 to 7 days, as opposed to having to take a medication every single day, which is what we were and still use for patients. The nice thing about that is that if we're able to capture people with 5 days of clarity, so once you get this injectable, it blocks all of those opiate receptors in the brain. So even if they use fentanyl, the fentanyl will not allow them to get high. They won't have that sense of euphoria. It also protects respiratory function, which means protection from overdoses. So once we're able to get those 5 days of clarity, people are much more likely to go and continue on receiving those ongoing services. And we've worked very closely with partners in the community, Bloom Psychiatry, Ideal Option, Camus Health, Healthy Behavior, and Function Clinic with Rockwood, to name a few, who then I can refer my patients to, and they are seen, and they receive 1 more injection, and that lasts a month. So then they're covered for an entire month and protected essentially from overdose. Again, if they were to go out and use fentanyl again or any other opiate, it would be blocked and protect them from going into respiratory failure associated to that opiate. The really, really encouraging thing that we're seeing with long-acting injectables is that the amount of people who are still involved in services at the 6-month mark is well over 70%, which is unheard of. We have not seen those kind of numbers before for retention in opiate use disorder programs. The other really great thing about those injectables is it becomes a monthly cadence, but as it builds up in the body, people are getting protection for 50 days from a shot. And so they're getting longer and longer stretches of periods where that medication stays in their system and keeps them level and feeling normal and at baseline. Again, the more time we get where people are like that, the less we have to fight addiction itself. So it is incredibly exciting. We're very fortunate that Multi-Care recognized that this was a concern, and allowed me to kind of, in a very bossy way, push this through. Deaconess is the first emergency department in Spokane offering this. We are the only emergency department in Eastern Washington offering this service. We rolled it out February 3rd. We went live, and since then we've given 11 injections. Our goal is to do 5 a month. We did 8 in the month of February alone. And then we're monitoring really closely, are those patients who come back to the emergency department, are they people that we're continuing to see with complications? And again, looking at, 8 weeks, little less than 8 weeks worth of data at this point, we are seeing actually some pretty positive things. We, again, work closely with our community partners, so we're able to track if patients are actually making those appointments. Our patient compliance has been very high. We've worked with the fire department, which is our next kind of expansion. As you all know, the fire department has 3 rigs that have paramedics that can give buprenorphine in the field following an overdose. So we're working closely with the fire department that if those patients are then transported to the emergency department at Deaconess, that they receive the long-acting injectable. We've had one patient that qualified under that. And I was able to get him sent back to his agency that he has housing and services through, and he was able to get that next injectable. I spoke directly to his provider. It kind of went exactly as we wanted it to. There are some limitations, of course. If a patient has used fentanyl or other opiates too recently, we don't want to put them into precipitated withdrawal, which is the big risk. So there has to be a window of time since their last use. My patients are really good about telling me that because they really don't want to go into precipitated withdrawal. For those patients, what we're still doing is making sure that they have a prescription in their hand of buprenorphine and Narcan when they leave our facility, so they at least have that. And then we make sure that they have a follow-up appointment. So this is just one more tool to kind of continue building on the programs that we've implemented for years, and hopefully start to make a little dent and a shift. I have received multiple phone calls from community members who have said things like, I'm really interested, I'm really scared, can I come in and talk to you? I've had patients come to the emergency department specifically asking about this. Family members of people who are stuck in the cycle of addiction, wondering, what they need to do and what the next steps would be. So we're getting really good feedback, which is what I think is kind of the most important part, but really a lot of ongoing conversation about how we treat opiate use disorder, and particularly how we treat patients who present with opiate use disorder. Historically, hospitals have not been a place that they've gone to seek care for a number of reasons, but stigma and bias being at the very top of that list. And this takes some of that away. Deaconess we want to be known as a place that's safe for people to come when they're seeking help. And opiate use disorder is as emergent as anything else. And we really should be treating patients as if they're coming in to be treated with an illness and not a moral failing. So we're hoping for good positive results. I keep saying if I have one person that's successful after a year, then this program has been successful. But looking at literature, I think that we can expect much bigger numbers. So I'm very excited to see where this takes us, and very proud of the fact that we work in a community that supports this kind of work as well, because it's not everywhere, I am finding out. So that's kind of it in a nutshell. I'll stop talking now.
Sarah, thank you for sharing that. Quick question I have for you. Do you have to have a specific insurance to receive this service?
You do not. It is covered by all insurances, state as well. Of course, if a patient's uninsured and they're at the emergency department, we're going to see them anyway, regardless, right? But the reality is that 97% of my patients or so carry state insurance. Um, and it is reimbursable like any other medication. So no restrictions on insurance.
Do they have to be enrolled with a opiate use disorder program to receive this benefit?
Nope, they do not. If they come in seeking help, we will treat them right there in the moment. If they're ready for the injectable that day, we will give it to them. We do schedule them an appointment. We work closely with Scala Northwest has a 24/7 scheduling line. So regardless of the time, day or night, patients will leave with an appointment for follow-up for their next injectable. And they do leave with oral buprenorphine as well as Narcan. So we have kind of a little bundle and some education that we give, but they do not need to be currently enrolled in a program. We can help them do that.
And can community providers refer to the program, have individuals do walk-ins?
They sure can. What ideally, most of our community providers are they've already doing this injectable, right? So the catch is that oftentimes they don't have pharmacies on site that have it in the moment. So we've had several community partners who have called us and said, they're ready for this injection today. I can't get it from Genoa or another pharmacy until tomorrow. Can they come see you? Absolutely. We'd be happy to take them. Like I said, this is a chronic illness and opiate use disorder poses a real mortality risk, which I think we sometimes overlook. No one should die because they've decided to use. So I tell my community partners all the time, if someone's ready in that moment, send them in. We'll help take care of it and make sure that they have next steps.
Excellent. Any questions for Sarah, for those on the call or in the chat? All right, see none in the chat. Going once, going twice. And Sarah, I didn't know if I heard this. How big is your team?
It's me.
For now.
For now, I am a team of one currently, but I am hiring a per diem social worker who will be starting at the end of this month. I had a peer navigator who moved on to another agency, so I am hiring to fill that role. I say I'm a team of one, but I actually work with some excellent providers who really push this through, great nurses who are huge advocates for this program. So even though it's me on paper, I have a lot of backing from staff in the hospital.
Excellent. Thank you so much for coming to share about your program and for working in an area to provide a service for a population that we know has been very impacted in our region. We continue to show high rates of individuals deaths due to opioids and fentanyl use. So using all necessary tools within our belt to be able to address that truly an epidemic in our region, not only beneficial, but does provide us the necessary data to identify where is the best service and need to be directed. So thank you so much for your program and also to MultiCare for supporting that.
Thank you all.
All right. Now this is the time of the show where we turn it over to the ASO to give updates on kind of what is the ASO doing. And this is part of the regional behavioral health contract we have with the state, as well as service delivery as it pertains to crisis services and other ancillary programs. As always, we don't cover all of the managed care or Medicaid services that are directly contracted out by MCOs. Of course, they can share on their updates if they'd like as when we go to the open topics, but this is specific to our region on those areas. And crisis does cover contracts directly with the MCO, so all individuals within that catch-all system. So I'll turn it over to Ashley McGee, our Integrated Behavioral Health Care Manager, to give us an update.
Thank you, Justin, and good afternoon, or morning still, everyone. Not quite there yet. So the updates that I have today to share are more specific to our crisis system. I wanted to bring forth some information on what we're seeing data-wise as we put forward many different investments and changes in the crisis system redesign over the past several years. Some of the things that we talked here today about with 988 and RCL and the development of our mobile dispatch unit to help with the transition of those services and ensure that we can streamline that mobile response out to our community. And as we were wrapping up 2025 calendar year, we did look at our data to see, what did we see over the last year with some newer programs going live, some of them really hitting kind of their full potential within the year, including the development of, endorsed mobile rapid response teams, putting together both our MRSS team and our child, youth, and family team into one team, providing 24/7 coverage, looking at some co-response updates as well throughout that year, and what we're seeing is are the numbers that we would want to see with those investments going into the place. So as Katie shared, with 988 saw a higher incidence of calls from the Spokane region. We saw that reflected in our RCL call volume. We saw about a 25% reduction of RCL calls within the last year of 2025. And that, it's important to note that there was not a reduction of calls overall between 988 and RCL, but we did see that shift of those calls moving to more 988 as that entry point, and RCL obviously is still mixed in there. With that reduction in kind of RCL calls or that shift, we still saw an increase in our mobile crisis outreach events by about 6% from the previous year. And I'll also indicate here that our youth mobile crisis outreach increased by 20%. And again, these numbers are for our entire region, our 6-county region. So 20% increase in youth mobile crisis events and about 3% in adult. So impactful numbers as we take a look at what we're seeing in our communities. Youth-based services, obviously that's been a focus across the state as well as in our region. And I will say that there's also an increase in the percentage of youth services versus adult mobile crisis services in the last year as well. About 2% for youth and a 2% reduction for adult. And then as we look at our IT investigations and detentions, as we see a shift in uptick in mobile crisis, our hope is that we'll see a reduction in the need for involuntary treatment. And we did see that this year. I think the first reduction we've had since 2021, where we did see about a 20% reduction in IT investigations in the year of 2025, and about a 1%, not very nominal, reduction in detentions based on the 2025 numbers, not statistically significant. I will also note that in 2024, we saw an increase in SUD detentions over mental health detentions. Still, mental health was the top percentage, but we did see that increase from 16 to 24% in 2024. And in 2025, we saw that reduce down to 20% for SUD detentions. And we do find that that's likely attributed to one of the SWIMS facilities in the east side of the state closing in February of last year. And all 3 available SWIMS facilities are now on the west side of the state. So though our region continues to utilize that pathway when needed and necessary, we did see an impact there. So all that data just to bring forward kind of some awareness, as these are the things that we're evaluating as we're putting these programs into place and evaluating how that is operating within our system of care here. So go ahead and pause here if there's any comments or questions on that. Not seeing or hearing any. I don't believe we're getting any in the chat. Justin, do you want to move on to the legislative impacts of RMP?
Yeah, so HCA did provide some updates on some of the reductions the ledge had this year that very specifically addressed R&P, which we will see an impact to our region. We kind of anticipated that there would be an impact as we went into last year. So we've been working with our providers for this service and identifying what ways we could bridge that gap, as well as where and how targeted these reductions could occur without actually negatively impacting any service delivery experience in the community. So we are working with those providers. We do anticipate there will be position impacts, especially the providers where they'll have to judge the funding, what that amount will look like, specifically in Spokane County, as that is our largest region, largest funded program. Again, we are working with Healthcare Authority to identify what funding could be freed up to bridge that gap. So now we don't have any specific or identified amounts that would be cut across the Spokane County region. We're still working with our regional partners on that. Thankfully, there was a lot of upfront funding that we did provide, so we shouldn't see any impact immediately. Even if there are reductions, providers should be able to have sufficient funding to continue in the near future at the existing rate of service delivery. Again, continuing to evaluate, trying to provide for the best in our region to reduce impact. Don't know if there's any questions on that, comments. Hearing and seeing none, turn it back over to Ashley for 1813.
Thank you, Justin. And thank you to Becky with the state, who provided a pretty robust update on kind of the precursor for what 1813 is and how that applies to kind of the work that we're doing currently. The Spokane region, we have 4 managed care organizations within our regional service area, and we have been working with each one of those 4 MCOs through these pre-delegation tools and readiness reviews as we move that work along, as well as working with them to initiate conversations regarding contracting. Again, with that time period of looking at the July 1, 2026 for go live of the expanded delegation of the crisis stabilization services. As I mentioned earlier, that really pertains to currently the services being provided at our Spokane Regional Stabilization Center for the mental health stabilization. In the future, that center will be expanded to incorporate the crisis observation or crisis relief services. And that will also be a component of that delegation, but that won't be until later down in 2027, early spring of 2027, as well as incorporation of the stabilization services anticipated up in Stevens County with the Alliance Crisis Stabilization Unit that is looking to open in fall of 2026. So not too much to report out yet, as we're kind of in the thick of working through those readiness reviews and contracting, but we anticipate by the next time we have this meeting, we'll have more to share on that. And I'll pause here as well to see if there's any questions or comments on that. Not seeing or hearing any, I'll go ahead and move on to the next agenda topic here. And Jessica Thompson, our OAC facilitator and supervisor, was unable to join us today, so I'll be giving the update on our OAC, our Opioid Abatement Council, which we facilitate for the Spokane Regional Service Area and participating local governments. We continue to meet as an OAC on a bi-monthly basis, and we are starting to receive the 2025 annual expenditure reports from those participating local governments. And as we are receiving those are being updated on the opioid abatement webpage, and we can get that sent out to this group if anyone needs access to that. It's on the Spokane County Community Services webpage. And with that, we are looking to update that webpage specifically and provide more visualization of kind of opioid settlement dollar expenditures and how those are being applied to the approved uses in the One Washington MOU. So in the future, we will be producing a OAC dashboard on that webpage that will identify the participating local governments expenditures for that year, and then what percentage of those are going to what approved uses, so we can have a better visualization for our community of how those dollars are being spent. A lot of counties are focusing on various different areas of the approved uses under the One Washington MOU, a lot on prevention, treatment, supporting first responders, innovative programming. So a lot more to come with that group, and hopefully a new way to look at that data as well. I'll pause here to see if there's any questions or comments on that. Not seeing or hearing any. Justin, I'll turn it back over to you if there's any other updates or for the next agenda topic.
Excellent. Well, this is the final part of the show. We turn it over to open discussion and walk-on topics. So for those that are in attendance, for our members and for those in the public, we will open this up. If you could raise your hand or put in the chat, that would be great. You can then see who may want to add a topic or discuss something. Going once. Going twice. Third and final call. Excellent. Well, we covered everything apparently, so I appreciate everyone joining in and participating in the conversation. One last call for any last minute public comments from any community stakeholders. Excellent. Hearing none. We have a scheduled next meeting for June. This follows in our normal cycle. So please mark your calendars now for Friday, June 12th. And please send us any agenda topics. Because we always try to match input from the Board of County Commissioners to align schedules, please note June 12th, but that may be subject to change as we look towards busy summer schedules. Thank you all for your time this morning and have a beautiful and amazing spring weekend. Take care.
Thank you.
Thank you all.